Hello, everyone, and thank you for attending today's webinar on payer collection challenges in 2020, lessons learned during COVID-19, and how to maximize reimbursement. I'm Richa Singh, Executive Vice President for CollectRX, and today I'm joined by Franklin Smith, who's our Director of Revenue Cycle Solutions and one of CollectRX's experts in payer collections. He's going to be speaking about lessons learned during 2020 and how to ensure that you're being fairly reimbursed by the payers. So for today, what we're going to do is we'll begin the webinar with a presentation, and then after that, we're going to have time for a question and answer session. So you can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. We're looking forward to hearing your questions, but if we're not able to cover them in today's session, we're going to have somebody reach out to you afterwards to answer them directly. Today's session is being recorded, so it will be available after the event, and you can use the same link that you used to log into today's webinar to access that recording. All right, so to start with, we're going to start with a quick overview of CollectRX and why we feel we're in a good position to talk authoritatively about payer collections. We'll then give you an overview of both the macro level trends affecting healthcare reimbursements in this unusual year and the aggressive new tactics we're seeing from the payers. We'll then discuss the key metrics you need to monitor this year, even more than before, and what you need to keep your eye on for the rest of the year. Then what we'll do is we'll provide some recommendations about payer collections that we suggest for this year. And finally, we're going to wrap up with that questions and answer session. All right, so to start, who is CollectRX and why are we in a position to talk about payer collections? So let me give you a quick overview of our experience in payer collections and in out-of-network more specifically. So that way you all can see how we are well suited to see these trends. Now, despite our name, CollectRX, we have nothing to do with the pharmaceutical industry. Simply put, what we do here at CollectRX is we help providers get higher reimbursements on in and out of network bills, and we maximize payer collections. Now, we don't do this as consultants, but more as experts in negotiating and appealing in order to achieve higher reimbursements on your bills and your collections. So, a little background, we were founded by the founders of the out-of-network negotiations and appeals industry. We've been singularly focused on helping providers get higher reimbursements since 2006. Over the time, we've helped over 2,500 providers nationwide optimize their reimbursements for in and out-of-network collections. We work with a variety of provider types, so this will include surgery centers, physician groups, hospitals, and labs. And to get the results we get, we rely on CRIXIS. Now, CRIXIS stands for the CollectRX Information System, and this is a proprietary data and analytics tool that we've developed to support us as we go toe-to-toe with the payers. Now, CRIXIS, it will help us analyze insurance policies. It provides comparable data to us while we negotiate, and it also allows us to track the tendencies and trends of the people on the insurance company side that we're negotiating against. Now, in addition to CRIXIS, we also rely on our expertise, and we've built a unique team of experts who used to work for the insurance companies and their vendors. This puts us in a unique situation to understand the soft spots in the payer positions and get higher payments on bills for customers. Now, in building the team at CollectRX, we focused on hiring people who'd worked previously for insurance companies and for their vendors to reduce payments on out-of-network bills. So companies like the ones that you see on this slide, Aetna, United Healthcare, MultiPlan, Viant. We also have in-house and outside legal experts. Many have spent their entire career dealing specifically with out-of-network bills. Now, as a result, CollectRX, we have an experienced team that understands how to combat the tactics payers use to limit out-of-network reimbursements. So let me switch it over to Franklin, to go over the trends.
All right, thank you, Richa. Certainly, CollectRX has a deep footprint in the out-of-network space, and I appreciate that description. And let's just talk about the trends for 2020 at the macro level and what we're seeing here. So number one issue that is going to impact healthcare providers billing patients this year is the challenge with coverage. Unemployment is an issue when it results in loss of healthcare coverage, and this year has been unprecedented. Before the coronavirus crisis began in earnest, there's about 210,000 Americans per week filed for unemployment benefits. But looking at the historical data, we know what things look like when there's an economic crisis. Like in early 2009, for example, near the height of the Great Recession, initial jobless claims reached 665,000, roughly triple the totals we saw in February. However, in March 2020, the data started breaking records in staggering ways. There's been some recent progress. In fact, today's number came out, I think it was lower than the 1.3 million that you see there from the Labor Department, but we have a long way to go to get out of this. Among people who said they or a spouse or a partner lost a job or were furloughed because of the pandemic, 2 of 5 had health coverage through the affected job. So among those who previously had coverage through an affected job, 1 of 5 said they or a spouse or a partner were now uninsured and without coverage. Despite that, we still see our denials going up. And based on the XFIN claim data in March and the beginning of April for all claims, there were an approximately 22% improper denial rate that we are seeing right now. And this has been managed with most of the payers and is down to approximately 8%, half of which can still be resolved with a phone call. The other half must go through an appeals process. So these improper denials have posed more of a problem for the COVID-19 antibody tests that we're seeing. In March and the beginning of April, there were approximately 43% in improper denials or missed payments done. This has been managed down again to approximately 25%, but we still have work to do in order to drive that number down. Our medical billing provisions in the CARE Act have led to an uptick in missed payments and claim denials that will need to be addressed by providers to ensure accurate reimbursement and compliant patient billing. In short, under the CARES Act, private health plans are required to eliminate copays, deductibles, and allegedly claim denials for COVID-19 related diagnostics and care. However, the data from the XFIN shows that some payers continue to charge copays and deductibles, and we have seen denials around the COVID-19 related claims, and particularly for the serology test for the antibodies. Out-of-network billing and collections continue to present a challenge in the healthcare finance. Both payers and government entities are presenting their so-called solutions to protect patients from enormous bills and relegating payments to out-of-network providers to try to reduce those payment rates. So our providers need to ensure that our revenue cycle operation is tight and that our procedures and policies and execution of those are protecting our revenue and giving us the best chance to maximize collections. One thing that has helped, or I should say, we have seen companies and people who have really benefited in some way from the pandemic and the disruption that we've seen. So while people have been losing jobs, furloughed from work, or cutting back on their healthcare needs and visits due to finances or fear of infection, our insurance companies have been making huge profits. United Healthcare Group has seen a $6.6 billion in profit in the second quarter alone, while Anthem and Cigna saw a combined increase of $1.5 billion during that same quarter. In short, the premiums are continuing to come and be paid, but claims are not due to the population's reluctance to visit healthcare settings right now. So payers are continuing to get paid and making a lot of money during this particular event. As we look at this slide here, it gives you an idea of where the country has been from a stay-at-home orders perspective, or some type of limit, if you will, in elective procedures that we're able to provide. that those colors that are blue and red indicates that there's some type of limit of movement within the society. So the disruption is real, and our ability to react to that disruption and make plans around how we can overcome the barriers that would come with them will be the key to our success moving forward.
All right, thanks, Franklin. So I want to take this back and talk a little bit more specifically in 2020 about some of the trends that are emerging in out-of-network claims. And the first trend is not using or paying claims based on the summary plan documents or SPDs. So just so we're all on the same page, a summary plan document is the agreement between the member or the employer group and the payer. The document specifies how the claim should be paid if the member goes to an out-of-network provider. So instead of following the plan, a payer may use a repricing company, and how that repricing company reprices the claim is a gray area. So they could be using Medicare plus a percentage. So it could be something like 100 to 350%, even if the summary plan document states that the claims will be allowed if you go to an out-of-network provider at usual and customary. So when the claims are repriced, the EOBs are misleading, both to the member and to you as a provider. The EOBs, they can have remark codes that say the member should not or cannot be bounced bill. The remark code can state on the member side that if the patient's billed, then the payer will work with the provider. But when you as a provider reach out to the repricing company, they won't negotiate with you. They won't discuss the pricing. And they say that they're going to stand on their data. And so that's when the blame game starts. Now, the repricing company, they're saying that the payer won't let them negotiate or increase the value, and they tell you to contact the payer. But when you contact the payer, they tell you to contact the repricing company. So it's this whole back and forth. And what they're hoping for is that the provider will just throw up their hands and basically give up. Aetna is one of the payers who's notorious for not providing summary plan documents when you request them. Most of the other payers like United and Cigna, they will provide you with the SPDs. Your alternative, though, is you can reach out to the member's employer group directly to obtain those SPDs as well. So the second trend here is that payers are completely repricing inconsistently for the same procedures. So we also see this frequently with Cigna, United, the other big three, and they either send these claims to repricing companies, or if they're not eligible for repricing, they'll allow the charges directly. So you may have the same procedure and bill it out for multiple patients, and even if it's the repricing company or the payer, they allow a different rates for the same exact HCPCS code. So for example, you have a United Healthcare patient who comes in for cataract surgery for the left eye, and the claim may be allowed and processed by United Healthcare. But then that same patient comes back 2 months later for surgery on the other eye, but this time the claim's sent over to a repricing company, and they process it at a completely different allowable. I mean, how can the same code be allowed at different rates and different ways for the same patient on the same procedure? We also see claims for the same code allow for different providers in different states at the same amount. And this doesn't make sense, because how can a colonoscopy in Los Angeles, California have the same value as a colonoscopy in a rural location like Warrenton, Virginia? They're supposed to be using, the payers, they're supposed to be using relative values and markup for profitability. And, you know, some providers, they are fighting back, and we completely support them 100%. I was talking to my appeals director, and she was just on a call for 2 hours with a law firm who had just filed in April of this year in the U.S. District for Northern California in a suit under RICO against United Healthcare, Cigna, and Viant, stating that they were perpetuating fraud from patients and out-of-network providers. So they're trying to use Viant now as a repricing company for legal practices, because I don't know if you guys remember this or if you know this, but United Healthcare, they lost a lawsuit in the state of New York in 2000 because they were using their own company, you'll probably remember, Ingenix, to set usual and customary. So that's their way around it. But now what they're doing is they're saying, hey, we don't own Viant, and Viant's the ones that's setting the pricing. All right, so let's talk about another ongoing trend. Our third trend here is that we see when a provider needs an authorization for treatment prior to services, which obviously they have to do, the payer then decides after the fact that, one, they don't pay the claim until they receive medical records, or two, they pay the claim and then request the medical records afterwards. And then they state that they will recoup the money even if they don't receive the records, or if they don't receive the records. So when you call in to request an authorization, they have utilization review management to give you the authorization. So why are they asking for more documentation? I mean, like, do they not trust their own nurses that already gave the authorizations? What this is it's a delay tactic. If they request medical records, you only have a certain amount of time to submit those records. If you don't get those records in on time, even if it's just 1 day late, they automatically reject the claim saying they didn't receive the records on time. And you as a provider will now have to submit it as an appeal, which adds much more time. Not everybody has time to check to see which claims are pending medical records. Because you're submitting an appeal now, the payer will also require you to submit other documentation along with the medical records, making it even more difficult for you. So they're basically hoping that the information they requested, it won't be sent. So for instance, United Healthcare, they submitted a request for medical records to one of our clients for claims going back up to 3 years, saying that they were going to do a recoup of over $1 million. Now, we worked these claims from July of last year, 2019, until April of 2020 this year. After we submitted the medical records, we contacted United Healthcare's audit department on a weekly basis for updates. Finally, we were able to get them to accept and agree to close out the audit, and we received a letter stating from them that there was no refund due back to by the provider. But this took like 9-10 months to resolve. So I'm sure you've also seen things like Payors, United Healthcare, for instance, they recoup the money from other patients, and it just becomes such a nightmare to resolve and to reconcile. So trend number 4 is that there are so many different types of pricing methodology that even the payer's own staff, they don't understand it. And Aetna is the perfect example. This is also why they don't want to provide summary plan documents. So they have a hierarchy of pricing methodologies that are loaded into their claim system, and it depends on whether the claim is manually priced by a processor or auto-adjudicated, to which pricing they actually use completely disregards the plan document anyways. So what you'll see on an Aetna EOB remark code is that it allows at a market fee schedule. It was allowed at Medicare plus a percentage, or what they determined as usual and customary. Because we've seen so many claims, and our CRICSIS database also collects that information and presents it depending on the employer group. And side note, employer group is really what drives how a claim should be paid. We know when to challenge and when to appeal those claims. We know whether claims should be allowed at Medicare, whether or not there should be a repricing company, and maybe it didn't even get sent to that repricing company if it should have been. I mean, you can call Aetna yourself and you can get completely different answers from 2 or 3 individuals if you call and ask them about their policies, and I'm sure lots of you have. So with trend number 5, the payers are more and more utilizing what they call their Special Investigation Unit, or SIU. These are departments dedicated to investigating claims and patient balance billing. They'll actually reach out to the member either by phone call or by written correspondence, asking if they're being billed. And then SIU is asking the member, what are they actually required to pay to the provider? The payers, they'll sometimes deny claims outright, or they'll make a small token payment. And also when they deny the claim, they'll state that in order to get the claim reprocessed, you must submit proof of a patient payment, which is ridiculous because, as you all know, out-of-network payers will reach out up front to negotiate a rate with the provider, but then they're asking you to adjust off the claim on the back end. So why do you as a provider have to show that you're balance billing and that you're not working directly with patients so that they're not responsible? It's ridiculous. Trend number 6 is the multi-layered approach to repricing companies. So that's a lot to unpack, so let me simplify it. What we're seeing specifically is that when we have an initiation of a negotiation request, meaning those prepayment settlement offers like from companies like Multiplan, we see the allowables topping out at very low amounts. So for example, we typically negotiate 90 to 100% on a majority of these settlement offers. But what they'll do is they'll top out closer to 30 and 40%. Then the claim goes back to reprocess on the payer side, has an initial payment, but then it gets filtered through another second silent PPO. But the good thing here is that we've been able to identify these claims and initiate the negotiation process a second time to push those allowables into the 90th percentile. Franklin?
So when we listen to that and we understand the hoops we have to jump through, if you will, in order to get paid for our services, we need to have our eyes on key performance indicators or specific metrics to judge how we're performing in our revenue cycle. So let's review some key metrics that are more important than ever before to monitor to ensure that we are able to collect the highest reimbursement amount. So, when we talk about key performance indicators, there are several of them. You have performances that are judging your payments, judging your revenue, judging your adjustments against that revenue, your denials, and where they're coming from, just all sorts of performance indicators that allow you to manage your business. But during this pandemic, during COVID, I'd like to bring your attention to the 3 reports specifically, your volume report and understanding where your patients are coming from. Are you open? Do you have a business right now where you're seeing patients? And what type of marketing are you and your providers doing to drive some of that participation? There was a time when people like myself and the revenue cycle folk were told to stay out of the pipeline. You just make sure that the billing and collection takes place, and we'll handle us getting patients in. But now, due to COVID and due to our having to keep our eye on our staffing and the costs around producing billing, we need to understand how we are marketing and what type of patients we're expecting to get and be able to respond to those. Then we have the billing report and those coding reports I'd like to also bring your attention to, because this is where we are monitoring our backlogs. As our flows ebb and flow, as our volumes go up, when the stay-at-homes are relieved, are we getting to those? Are we able to bill for every patient that we've seen, and how we are reconciling that? How do you know you've done that? From a coder's perspective, and the challenges that come with our providers working from home or our coders working off-site, are they able to access the records? Are there any backlogs due to the fact that where they are working or how the process has happened before has changed? Are they creating backlogs where you cannot get your claims out, or you need to get some type of supporting from a vendor or something in order to code those claims to move your bills down the pipeline? But for 2020, the year of our Lord here, the challenge that this has been in my lifetime the most challenging year I've experienced. There are some additional reports that you want to use right now to help navigate some of the specific issues that many providers are experiencing. Additionally, there are some standard reports that you can slice and dice in different ways to provide insights that will enable you to stay on top of some of the issues that may come up this year. With up to 22% of the denial rate this year, oftentimes they are resolvable, as we said, by a phone call, but you have to know why they're happening in order to fix those issues. So having reporting that, bucketize what's going on in your receivable, first from your claims that you bill out to the payer, and you're doing your account receivable follow-up. What type of payer delays are you receiving, and where are those delays coming from? Bucketize them by payers so you can understand the experience you're going through with that payer, and if there's any type of sudden changes that are happening with it, you are able to adapt and make the appropriate changes to overcome those. And more than anything, while bucketizing, and understanding what's driving the issue, you're able to do some type of root cause analysis to eliminate them versus just treating the symptom and correcting the problem over and over again. So we've seen telemedicine really get hot during the pandemic, again, with patients really not feeling comfortable with entering into healthcare entities for obvious reasons, fear of infection, or just wanting to comply with local orders for stay-at-home um, um, initiatives and whatnot. We've seen telemedicine increase. The government has tried to make telemedicine more acceptable, I should say, or compliant for providers, and making those rules pretty consistent across state lines. But there's still a lot of diversity in the way telemedicine claims should be billed, the way we're seeing payers respond to them and pay them. So that I have some suggestions on what we can do to manage our telemedicine process if it's happening. Number one, have a billing report about a procedure type, focus on the telemedicine type of E&M codes. So you can check to see if there are any type of anomalies that are coming from the payer, whether they're being denied, whether they're not being paid due to man necessity or some other type of payer delay that you're seeing. But bucketize those also, respond to it, and see how you can overcome that. Use that information to understand whether you're being underpaid or understand whether you're credentialed correctly if your denials are continuing to happen. Develop your blueprint by payer, by state. If you see changes or you see those small nuances that are necessary in order to get your telemedicine bill paid. You need to understand what the billing requirement is by payer, by state, so you can send in a clean bill and get reimbursed for that service. We showed in the slide earlier, how the unemployment is affecting healthcare, or our jobless claims, I should say, and it's having a direct effect in healthcare. I mean, the main thing is that we need to understand the patient responsibility is going to be more challenging right now. That the loss of insurance and an increase in the patient share that we're also seeing from benefit changes, it's going to take longer to get that paid. You need to work with your team to have scripts available with those patients when those time of service payments or those discussions about the patient share happen. And you need to be, in my mind, a little lenient, allowing for a little longer payment plans, if you will, in order for a patient to satisfy their responsibility. Implementing a financial assistance program or a hardship program to discount services heavily if necessary, to allow our patients to continue to get their healthcare needs served and meet their patient responsibility. Use your aging reports also to see and track how that revenue is moving and whether or not you need to take specific actions in terms of using a vendor or some other type of support to move those patient receivables faster. We've all, have used days outstanding as a measurement of how well a particular billing operation is going by payer. I think during this whole COVID-19 disruption and pandemic that we're going through, this particular indicator is even more valued. This has a huge potential, if you will, to get out of control very quickly, particularly in those states where stay-at-home orders have been issued. For payers, for instance, what payer stands out? Who is your problem child? In order to know which payer stands out and who your problem child is, you need to have at least a baseline of what your days outstanding report by payer was prior to the pandemic. So you want to do some gap analysis and see, at what type of increases or what threshold of increase do you want to highlight when they reach a certain point, so you can, take some mitigating actions with that payer to try to change that particular outcome. You need to also, be able to communicate to your higher ups whether or not the payer itself is shut down. If the payers shut down, then any appeal or any type of claim that needs to be adjudicated that will require a human to do so, those particular payments and processes and claims will be delayed until those folk return to work. So you want to make sure that you are sending out the cleanest claims possible and that you can reduce the payers rejections, if you will, and get claims paid on that first payment as much as possible and at the highest reimbursement amount that you possibly can. And then just stay on top of those claims that are aging out and getting older, making sure you have processes in place when you're following up on those to ensure that those claims have been received by the payer and that they are going through the processing or the payment payment processing that needs to happen for you to get your money. From a patient's perspective, again, we just need to understand that many patients are under financial pressure today, unlike they've been at any time in our lifetime. And we need to adjust our write-off or our collections processes in accordance. Let's practice our revenue cycle, if you will, in the patient's obligation field with a heart. Let's make sure that we're serving our patient and helping them get through this trying time. And develop a plan to manage it with them, to track it with them, to provide financial counseling if necessary. Richa talked about, payers and their payer delay tactics by responding and asking for additional information or medical records and things like that. But the reason they do that because oftentimes you have a timeliness, let's say, of the initial bill of being up to 6 months or up to a year, which is plenty time, and it ought to be plenty time for you to get your bill coded and sent out to the payer. However, once they reject it and ask for additional information, many times that timeliness changes and it goes from a 1 year or 6 months to 60 days or 90 days to respond, or that claim is denied for timeliness. So you want to review the receivable and identify all accounts and revenue that is at risk for this timeliness. That includes your initial bill submissions and, again, any appeals that you plan on taking. Understand the rules by payer and the timeliness that they give you to know what's happening and how to remedy this particular situation. Negotiate for timeliness relief from these payers. If your operation has been affected by the pandemic in the sense that the stay-at-home orders have prevented you from being able to staff your operation, document that. Use it as an appeal with your payers, get on the phone with them and make a case as to why you think you should be forgiven for any timely filing appeals, particularly during that period between March and this past June. And quite honestly, as we look at how the pandemic and the COVID is spreading, just until we are out of this, use that. Hospitals have been appealing these timely filing denials and have seen some success from that, and I believe physician offices should follow suit and do the same. So in January and February, we were all driving to work in normalcy. We were seeing the news about this particular disease that was coming over from China, and we were seeing what was going on in Italy, but we were still driving and going to work. And then all of a sudden in March, I know in Maryland in March, all things stopped because the stay-at-home order. So resources and their ability to come to work changed. They could not come, but the work still needed to be done. This, of course, is a huge change for everyone. So how are you ensuring the outcomes you want to reduce are going to happen? A lot of employers have seen productivity increase, but how will you know if you're not measuring it? So you need to ensure that you are measuring your productivity, that you are staying engaged with your staff, and that you have designed a work program that works for them and you in order to get your outcomes. Also understand that everybody's work at home situation is not the same. There may be challenges for one of your staff members that none of your other staff are dealing with. So you need to care about them. You need to understand exactly what they're up against and try to work with them to provide the tools they need to do the work that you need them to do to produce high cash months. So if your resources are remote, are they going to be part-time? Are they going to be full-time? Are you going to judge the productivity of both of them the same way, or will there be some nuances and changes or different ways to look at them because of the type of employee that they are? How are you updating your key performance indicators to judge that productivity in the correct way? Do work assignments need to change, or should you put a little bit more on another employee, I should say, that has more of a range of talent in order to deal with multiple payers, while you sort of like streamline the work of another due to their work at home situation? How has your response to the new worker changed? Have you been receptive to it? Have you been able to problem solve with them, or have you looked at it in a frustrating way and thrown your hands up and say, I don't know what to do with this? Our attitude toward what we're going through will be key to us overcoming this challenge during this pandemic period. And we need to approach this as if we can knock all the walls down in front of us to get this job done. And if your state is to close, and we're seeing where these orders are being relaxed at times, then the numbers are going up through the roof, and then the stay orders are coming back in. So what is your resource plan, or how are you able to adapt to this if you happen to be in one of those communities that has opened up, your staff returned to work, and now you're facing the fact that you may have to close again? Make sure that you have a plan to deal with that, and partner with your vendors. Have a relationship set up with vendors in case that comes along, so they can step right in some of those cases and keep your business processes moving down the line. So what do we want to look at for the remainder of 2020 to make sure that we're keeping our doors open in our facilities? And again, the biggest threat is the instability in our cash flow, and understanding, the factors around why we are having these issues. So as we move through the rest of 2020, there will continue to be impacts to your cash flow that you would need to prepare for. Recognize when they occur and put a game plan in place for managing it. These include, again, the sporadic COVID-related closures, any reduction in your patient volumes that's going on, or when the patients come back, any type of adjustments you may have to make in order to ensure that revenue is protected. Higher volume of uninsured. People today, maybe you scheduled, they showed up 3 weeks ago, they had insurance and they wanted to get a service or at your operation, and now today they're uninsured because they lost their job, or their partner or their wife or husband has lost their job, and now they don't have insurance. So you'll be dealing with the patient's inability to pay. And so you have to deal with that, because you have to have some sort of patient payment policy in place to stay on the good side of the payers in the out-of-network space, so they will suspend you or put all your claims into a medical record suspension status, and you would cease to get payments. So you have to meet this patient's challenge of payments, if you will. You have to meet it head on and just develop policies, whether it's a financial assistance policy or some type of hardship policies that you're following for every single patient, but they are somehow making some type of payment to you on their responsibilities. And then, of course, delays associated with payers closing. They will close too, and you will need to communicate that to your higher ups as you're discussing the results of your operation. So, despite the fact that payers are making boatloads of money right now, they are not trying to figure out how they can give that money back to the providers or split it with us in some way. In fact, what they're doing is really increasing the barriers we have to getting paid. And so, look, they're going to run into fiscal difficulties in these upcoming months and into the next year, because we've heard and we've read about the so-called second wave, and we've seen our COVID numbers begin to increase in various states throughout the nation. So the higher profitability now doesn't ensure it later for these insurance companies, and they will see increased costs related to COVID claims being submitted by our hospitals. So what's happening is we have legislative and regulatory approaches to trying to help and fix this, where you have surprise billing legislation that's being considered in several states that's spilling over into the out-of-network space. They are benchmarking some of the rates by localities to see if they can do some rate setting and control what's paid to the out-of-network provider in that particular way. And then, of course, in this election year that we're faced with, and that whole fear, at least a fear of mine, of Medicare for all and how that might affect reimbursement during 2021, 22, and those years moving forward. All of those are things we need to be concerned about and have on our radar and be watching to ensure that our practice has a sufficient plan to deal with it. And then, of course, we always have our good old friends of increased denials, underpayments, and payer delays based on medical records, itemized bills, and anything else they can come up with to try not to pay us. So when you run into sporadic closures, increased spikes in your area, or generalized restrictions to your patient volume cash flow, do you have a plan? Are you sufficient in your resources? Are you able to have a contact at the payers where you can call and pick up the phone to talk about any mitigating issues that mitigating plans you'd like to implement? And are you actually having conversations with your patients as they're scheduling to ensure that you're discussing their out-of-pocket and how they can satisfy those? All of those are considerations we must make at this particular time.
All right, so I'll take over from there and talk about, with the cash flow issues, what are some of the strategies that we can leverage and stabilize collections, basically. So simply put, what we want to do is we want to focus on collecting from payers, not patients, because patients have less disposable income and payers, of course, have more. This can also help you build a better relationship with your patients. And what you need to do is make sure that you're collecting from the payers what you're entitled to. And providers today, of course, we're collecting less and spending more than they were historically. Denials and underpayments, they continue to increase. Unpaid claims remain unworked. And there's a lack of visibility into what's driving AR and how to improve future AR performance. Couple that with the fact that it costs 4 times as much to collect from patients as it does from payers, it becomes very clear that your attention needs to be laser focused on payer collections.
So what's the most important step? Okay. And that is to focus your attention on the AR and the payer collections. I mean, set a goal and meet it. We need to understand, how to set our cash goals. We've had clients, or during my experience, there have been those physician operations or RCM operations that they have a cash total, and the cash total is a number that they averaged a year ago, or it's a number that the doctor feels that they should be collecting on a monthly basis. But during this pandemic, those types of goals just don't work. Your goals should be based on some type of percentage of or the volumes that you're seeing and some type of net collection against the charges that those volumes produce. Okay, you have to set your goal on that because the volumes are changing. One month you can be returning back to normal and reaching certain census amounts that you've done prior to the pandemic. Then the numbers go up during the pandemic. We have a stay at home and your volumes go down. But then your cash goals can't remain the same in those scenarios because you're not billing out as much. So you have to have your goals tied to that percentage and know exactly what is expected as a collection amount, and then meet that. Drive your procedures, drive your setup, your resources to go after that specific goal, and stay laser focused on it by payer, by department even, and by specialty to ensure that the financial profit or the financial viability of your practice continues. And then, as you measure your days outstanding, communicate to the higher ups, particularly in those scenarios where there's a stay-at-home order or there are restrictions in terms of the movement of people. And let them know that there are days in AR per payer may increase. But then also have a plan on the back end on how you're going to get those days reduced over a certain amount of time. Do not sit still and accept what's going on as the rule of law. Project out in some way, form, or fashion on what resources would be needed, what plan would need to be acted on in order to get cash flow back to where it was pre-pandemic, and to ensure that you're following up and generating the cash it takes to be a thriving business. Now, front end, front end, front end. Whether there's a pandemic or not, we need to protect our revenue up front. Okay, and so obtaining benefits, getting the eligibility of the patient, ensuring that they have out-of-network benefits that are acceptable there, all of that is important to ensure that the service that's being rendered will be paid for down the line. So we want to verify benefits when the visit is scheduled, and then we want to verify the day of the procedure. When people are getting laid off, they're forgetting to apply for COBRA, or they can't afford COBRA, and they don't have coverage for the day of the procedure. Even if they have insurance, sometimes they may not have the out-of-network benefits that I just talked about. So consider what type of financial counseling you may want to provide for those patients who have large deductible plans and things, or have a high out-of-pocket. Again, consider using a hardship process or some type of schedule or policy where you're set up where they are required to meet some type of patient portion obligation. In the out-of-network space, we could be creative there. So, but just ensure that you have a policy and you're executing that policy for every patient that you see. And when you're getting your authorization, don't rely on the physician and their staff. If you're a facility, the physician can't get the facility off. They can only get the physician one, not both of them. So do not listen when the payer says that it isn't required either. Okay. You need to make sure when you hear that from a payer that you document the name of that person, or what they communicated to you and why. Put that in those notes so down the road, if there's an appeal that needs to take place because the authorization was actually required, we'll have information there to do so. Your staff has to be the upfront experts in getting these authorizations. And again, document everything every time you talk to the payers, every time. And I'll say it again, document, document, document. Get names and phone numbers, specifically document who said what and when. We can deal with it and for denials of man necessity. But when you don't have that type of information documented, you really have no chance to overturn the no authorization denials. And the benefit verification, we want to verify the type of plan that they have, whether or not it's self-funded, whether it's a usual and customary plan, or whether it's a Medicare fee limit plan, such as the MRC 1s or MRC 2s of Cigna, for an example. Then if you have payers that have a specific form that they require of their patients in terms of assignment of benefits or an authorization, make that a part of your welcome packet. So when the patient presents, you can get all the signatures that are necessary for us down the line in case there's an appeal to come. We'll be able to, your people who are doing the appeals will be able to grab that form, submit it in, and get those denials overturned.
All right, and yeah, let me take it from there with the appeals. And it's just another way that you can increase your collections is by ensuring that you're appealing all out-of-network underpayments and denials. And as we noted earlier, denials are at an all-time high, and you have to appeal them if you want to maintain your collections. And it might seem pretty obvious, but going back over your out-of-network claims and reviewing them for underpayments and denials is really one easy way to supplement your cash flow right now. Since these are non-contracted claims, this is a key area to focus on to increase your collections. And we deal with these payers every day, and they've become much more aggressive on out-of-network claims in the past year. So chances are you've been underpaid on many of them. So let me show you an example of doing an analysis over the last year. Now, let's say that your facility generates about $5 million in net revenue, with 15% of it coming from out-of-network patients. In a typical scenario, CollectRX, we can increase providers allowable by 1/3, meaning that the payer increases their usual and customary amount by 33% for you. In this scenario, that would mean an additional $250,000 in reimbursement and profit just from that analysis. Putting it another way, suppose you were in contract with a major payer who comprised a small portion of your business. If they offered you a 33% increase in your reimbursement rates, you'd be thrilled, right? So that's the type of opportunity that we're talking about here with appealing your underpayments. The first thing to know is that the payers are always looking for ways to control costs, meaning the amount that they pay out to providers. One strategy the insurance companies use is the outsourcing of bill minimization tactics to third-party vendors that specialize in helping payers reduce payments to providers. And they do this through two main ways. One of them are those upfront negotiations that you see with settlement offers or proposals, LOAs. The second one is repricing services. You may have heard of the companies like MultiPlan, Viant, NCN that we've mentioned throughout this presentation. And it's vital to understand that these are cost containment companies. They're employed by the insurance industry to reduce payments to providers. And I mean, do yourself a favor and you just go and look at one of their websites of any of these companies. You'll see it all laid out even on the first page. Their goal is to maximize the discount. And why? It's because that's how they make money. The vendors, they're compensated on a commission basis. So the greater the discount, the higher the commission. Now, I mentioned this briefly before, but it is vital to obtain the data to prove that the insurance company's payments are inadequate. You need to be able to argue that the insurance company's reimbursement level is inconsistent with your own history and preferably the history of other providers in your area. Now, here's a couple screenshots from our CRICSIS database that shows how we use real-time comparable data and analytics to show where allowables should be. Our data can be broken down by payer, plan type, geography, specialty, and so on. And the circles on the bottom chart, they indicate specific cases that can be drilled down to use for comps, so we can learn the success of other negotiations that are similar to yours. Now, some other steps for the appeals include reading and understanding your EOBs. This is easier said than done, as EOBs are often difficult to decipher, and they do this by design. I mean, if there's one takeaway from today, is to check your EOBs, because if you don't, frankly, you're losing money. Similarly, with your AOBs or your assignment of benefits, you need to have a well-drafted assignment of benefits that includes the following. So take note. One is it assigns the right to appeal and the right to receive relevant documentation, as well as some other rights. It refers to the provider as the patient's authorized representative, and it should properly reference ERISA and a full and fair review of claims. Franklin talked a lot about this, but with so many people changing coverages right now, it's more important than ever to verify benefits, not just when the appointment is scheduled, but also the day of. You need to verify that they have coverage and that it includes out-of-network benefits. For negotiations, when the vendors opt to settle a case through one of those upfront negotiations or settlement offers, they often do so by sending a proposal that often has a short turnaround time for a response. And their goal is to put pressure on the provider to settle quickly. Sometimes these turnaround times are real, but sometimes they aren't, and they're just trying to use this as a scare tactic. Third-party contracts. Vendors sell contracts to providers that promise great rates. The catch here, and what they don't want you to know, is that they're applying various cuts, such as usual and customary cuts and multiple procedure reductions. So many times your final rate is a fraction of what you thought it would be. That is, if you checked, of course. Many providers, they don't even track their payments to see whether they are being paid correctly. So remember, these vendors, they work on behalf of the insurance companies to save them money by reducing payments to you. Knowing that any contract you sign with them is really a cap to your reimbursements and a saving to the payer. Then we have what's called the persistence game. So who's going to win the battle of the wills? The payers and the vendors, they put up obstacles to success, banking literally that you will give up and walk away. Their goal, their sole aim, is to get you to throw in the towel because they know you're busy and they know that you don't have the time always to continue the fight. And remember, the vendors, they're paid on a commission basis. So when you give up, they win. Ultimately, to succeed, you must have the persistence to continue fighting for the reimbursements you deserve. And then finally, for this part of the slide, we hear providers say all the time that they have a great relationship with their vendors, and it boggles my mind. That's exactly what they want you to believe. But you have to remember, these vendors, they're not your friends. They're compensated on how much money they save their clients, the insurance company. And they're continuously trying to find new ways to pay you, the provider, less money. Now, working on all of your denials and underpayments and retiring bad collections is another way to increase your cash flow right now. So why do we recommend this? The challenge of getting the highest reimbursements possible for your charges has never been more daunting. Even prior to the current challenge of COVID-19, the payers and the insurance companies, they've executed a campaign to reduce payments for as many encounters as possible. This slide shows how that plan's executed. We talked earlier about some of the games out-of-network providers participate in to get the desired dollar in the bank. In addition, payers continue to challenge providers through revenue leakage in the form of denials. And the additional work required to resolve or respond to these deductions, they've forced many billing and collection operations to consider how or whether to address it. So is there value in paying attention to your denials? We say you have no choice but to do so. And many billing operations that we deal with across the country, they share the key reasons why appeals or denials often go unaddressed. And many times it leads to low cash flow and in some cases, reduction in operations. The expertise needed to produce overturns do require specific skill sets. It requires negotiation skills, data gathering and retention, and historical trending are all bullet points to success that providers need to have in place when they choose to appeal. And the overwhelming majority of providers, they just don't have that skill set within their team. Form letters make us feel comfortable because, something's quote unquote being done. But the real work here is to spur more cash in, and it's not easily recruited. When we find that right person for the role, it ends up that person costs a fortune. All of these are barriers to overcome when deciding to move forward with an appeals program. And right now, actions can be taken to enhance your cash flow in the midst of the COVID-19 experience. So I know we're running out of time, but want to go through a couple of these. Look at your legacy AR cleanup. Research, appeal, reconcile your outstanding AR to identify potentially collectible accounts and pursue payments or recommend the appropriate closure. Look at your current AR follow-up processes. Follow up with payers to get timely and accurate payments by monitoring the status of claims and contacting the payers to identify the current status of the claims will make a huge difference. Then determine if anything is preventing the payer from making a payment and correcting those issues. Denial appeals. Conduct a complete review of all denied claims for the past 12 months and undertake actions to secure payments if possible, or recommend and complete adjustments on accounts as warranted. And then payment posting and balancing. Ensure that all incoming insurance ERAs and EOBs have been posted, as well as any patient payments for full revenue integrity. A fifth strategy for stabilizing cash flow is to leverage technology to increase productivity and reliability to reduce human error. So analyzing claims is extremely challenging when you're using your billing system alone or you're using manual approaches. When you use technology to help manage the payer reimbursement process, you're able to do more with less. Automated data analytics allows you to quickly identify and prioritize at-risk accounts before they become a problem. Then you can leverage workflow technology to assist the path through each claim, ensuring that nothing falls through the cracks or is missed due to oversight. So quickly, I want to talk about bots. Bots are automated agents that scan payer websites and automatically update you about the status of payments. Feeding account statuses eliminates the need for you to have to follow up every 7, 10, 14 days because these bots, they're continuously pinging payer websites for you. Now, the benefit here is that it ensures that you get statuses even before you receive the 835, making your staff more proactive in working your accounts. And using bots can ensure that your team is making the proper touch at the proper time. And there's a bunch of vendors in this space that can help you set this up. Just keep in mind that you need to ensure the bots are driving workflow, not just bringing back the data. Another benefit leveraging technology brings is centralized data. It's very important to have all of your data in one place talking to each other. Everything from your billing system to your clearinghouse to payer websites and workflow tools, everything should be automatically pulled into one place. Having your collectors work out of one primary system will help streamline processes and their effectiveness. And having data is important, but automation is the key. I mean, just think about how many collectors it would take to do all of this manually. And leveraging workflow automation can also help you increase your collections. So understanding workflow is so critical because, as Franklin was saying, the most common issues on the back end of collections are caused by breakdowns in the early parts of the revenue cycle. Things like clinical denials or incorrect claims data. You need to dissect your workflow and identify weak links on the front end in order to help increase cash flow and reduce aged AR on the back end. Automatic rules assign follow-up based on sets of criteria, such as stage and time since the last follow-up. You can also assign based on tasks like follow-up, documentation, billing coding review, and then you can also have timeline-based assignments, so never miss another deadline, again, with workflow that's tied to your payer's timeliness. So as we go through 2020, chances are you'll run into some of these trends in out-of-network payer tactics. When you do, just remember that you do have plenty of tools in your toolbox to combat them. The best way to combat them is to be prepared. So again, I know that I've gone over. I do really appreciate this, that you guys have sat through this. I hope that we provide some good information that you can use in your daily practice to ensure that you've been paid equitably by the payers in a timely manner and that your claims aren't being denied unfairly. Out-of-network is a good strategy for many practices. We hope that we've been able to help you integrate it into your daily processes. I want to try to answer a couple questions, just maybe one or two before we jump off. Hopefully it's your question. The first one here is, how can we, Franklin, I'll ask you, how can we avoid the special investigations unit?
Oh, yeah, you want to avoid the special investigations units if at all possible. These are often triggered when there's absolutely nothing collected up front from the patient. If you do balance bill, you have to attempt to collect something up front. So long as you show you did something, you've made your good faith upfront effort. And then secondly, we can argue that they are balanced billing collecting so long as there's something collected up front, even if it's just $20. In the bill versus collect, it doesn't work anymore to just send the bill out. You have to show that you actually collected the payment.
Okay, great. I want to do one more real quick, and this one I think you should answer as well. What are some of the most common denials you're seeing, and how can we avoid them?
Number one, I'll say it again, we want to make sure that all the billing and coding on the front end is clean as possible so you don't give them any reason to deny. Let's start with that. But again, you want to make sure your benefits, eligibility, and authorization processes are in place to serve as your first defense of collecting all dollars owed. Then we need to understand, particularly in the ASC, that some CPT codes are not covered. We see ASCs billing for non-ASC related codes, so we need to understand that. We need to make sure that they are collecting the right information up front, i.e. the right procedures were done before they went in for surgery. If there are any global periods that are associated with it, make sure it's included in the global period there. And then last but not least, access the clinical bulletins on each of the payers' websites to make sure the procedure codes and diagnosis codes are approved for that particular treatment.
All right, awesome. So yeah, there's many more questions. What we'll do is I want well, first off, thank you all for who's stayed on with us for so long, and I hope you guys found something out of this. If we haven't answered your question, what we'll do is we'll get back to you in the next couple of days to get you an answer. And Franklin, thank you so much for your excellent presentation. Yeah, and everyone else, enjoy the rest of your day, and we look forward to having you on future webinars. Thanks again.
Take care, everyone.